Good morning, good afternoon, good evening, everyone. You're welcome to today's episode of Public Health in Real Life, a channel where we aim to inspire the next generation of leaders, celebrate unsung heroes, and highlight key global health issues. Today's episode, I have the pleasure of welcoming my co-host, Dr. Njai. Dr. Njai, welcome.
Yes, thank you, Eminat. So I am. Yes. So I'm Dr. Abdul Njai from Sierra Leone. I'm a public health advisor with a clinical background and with a lot of interest in health financing and universal health coverage. I'm happy to be here.
We're happy to have you, Dr. Njai. So for today's topic on public health in real life, we'll be talking about paying for universal health coverage. Why, what, how, and for whom. We have the pleasure of having our guest today, Dr. Adanna Chukwuma. Dr. Adanna is a senior health specialist in the Health, Nutrition, and Population Global Practice Division of the World Bank, where she leads the design, implementation, and evaluation of investment operations. She has over 10 years of experience advising national reforms to improve access to high-quality healthcare through service delivery organization, strategic purchasing, revenue mobilization, and demand generation. And her work has spanned countries such as Sri Lanka, Sierra Leone, India, Moldova, Tajikistan, the South Caucasus countries, and Romania. She has published on healthcare financing, access, and quality in several peer-reviewed journals, including the Bulletin of the World Health Organization and Social Science and Medicine. Adanna obtained a medical degree from the University of Nigeria, a Master of Science in Global Health from the University of Oxford in the UK, and a Doctor of Science in Health Systems from Harvard University here in the US. You're welcome to today's episode, Dr. Adanna.
Thank you very much, Dr. Memunat. I'm looking forward to the exchange today with you and Dr. Njai.
So straight to business. We captioned this discussion, paying for universal healthcare coverage. What, why, how, and for whom? Considering the varied background of our audience, can you please explain what paying for universal health coverage means and why our audience should care about this?
That's a very good first question, Memuna. And so it's a long title, but the two essential pieces of that title are paying and universal health coverage. Paying refers to the purchasing function of health financing. So if health financing, is seen as triplets, revenue raising, pooling, and purchasing, then purchasing is sort of the underappreciated sibling in the health financing family. It is the function where we allocate the resources we have mobilized and pooled to specific health services provided by healthcare providers, right? And so what would this include? Purchasing decisions include things like, what services are we paying for, right? Are we paying for maternal and child health care? Are we paying for NCDs? And what standards are we holding those services to, right? So what level of quality do you have to be referred to receive those services? Which people can receive those services? Do you have to pay any amount of money, a co-payment, a deductible, out-of-pocket payment of any sort to receive those services, right? So that is what are we paying for. The second important dimension of purchasing or allocation is who will provide those services. So countries will decide, do public sector providers provide services? Do private sector providers provide services? And what kind of provider, right? Do they have to have some kinds of equipment and some kinds of training? What standards do we hold providers to? This might be checked through accreditation or licensing. So far we have what are we purchasing or what are we paying for? We have who are we purchasing from? And then we have how are we going to purchase, right? So here we think about provider payment mechanisms. Are we going to pay per service? Are we going to pay per person? That is called capitation. Are we paying for specific kinds of cases in a specific way versus others? Are we paying a fixed salary? For example, when I worked in Nigeria, over a period of time, I'm paid a fixed amount regardless of what I do. And sometimes we pay hospitals what is called global budget. For a fixed amount of time, this is how much money you get, right? And then for all these decisions, what services, how are we paying for them? From whom are we getting the services? We have to define the governance arrangements. Who is going to make those decisions? What are their roles and responsibilities? What information are they going to use to make these decisions? And what capacity do they need to make those decisions, right? And so this is all the dimensions that ordinarily fit into purchasing, right? And then now we turn attention to the second part of the topic, universal health coverage. And so this is a term that I think over the past 10 years has become a lot more popular. It refers to the idea that we are moving towards a situation where everyone, that's the universal piece, has access to essential services of significant quality, enough to ensure that their health improves, and that importantly, we protect them from financial risk at the individual level, right? And so our topic of paying for universal health coverage is reflecting on what are the ways in which how we allocate resources, what we're paying for, how we're paying for it, from whom affects universal health coverage. So why should people care, right? So the reason is this. If you think of a graph, right? You think of a graph, on the x-axis, we have how much money countries are spending, right? And then on the y-axis, you have universal health coverage, an index that is measuring how many people are able to access essential services. Now, if we plot all the countries in the world, we find that as you spend more, your level of coverage in terms of universal health coverage goes up, right? So we are able to reach more people. But interestingly, at each level of that graph of health spending, there's a lot of variation. For example, in a recent paper in the Lancet, for countries that spend around $500 purchasing power parity annually, the range in terms of universal health coverage on a score from 0 to 100 is from 40 to 75. Now, that's a huge range, right? So, many times when I sit across ministers of health and we're thinking about the challenges, preventing us from getting to universal health coverage, there's a lot of push for more money. We want to spend more money. What a graph like the one I described shows is that while more money is important, it's also important to reflect on how we are spending that money. And that is where the paying discussion comes in. That is where the purchasing discussion comes in. And so, we have just 1 hour, not a lot of time, but I'm hoping that between, members of the audience that have experience and some of the discussions I have had, with ministers of health in different countries, you can sort of point at why are these decisions in purchasing really important for thinking about how far we go in terms of universal health coverage. So back to you, Maimuna.
That's definitely a very interesting expose, Adanna. And I'm glad you mentioned how everybody's talking about universal health coverage. And most times people think about universal health coverage and think about pumping more money into the system, which is necessary in terms of health financing. But I'm glad you're really highlighting the often neglected aspect of purchasing within healthcare financing. You recently co-authored a publication in Health Systems and Reform that explained the ways in which purchasing agreements in Armenia, one of the countries you work with in the South Caucasus, may be negatively affecting utilization of care, financial protection, and quality, which are all objectives of the universal health coverage. Can you provide a high-level summary of your findings?
And we'll try to do so. A high-level summary is always tricky, right? So you spend weeks and months trying to get this paper out, and then now you have to start. So 5 minutes, let's see. The motivation behind the paper that I co-authored with colleagues from Armenia and colleagues from the bank is that we've been in intense discussions with the government for about 3 years or so, on what we're calling the second generation of reforms. Armenia was an early reformer among the post-Soviet states in the late 90s, early 2000s, right? They transitioned from paying, salaries and for inputs like health workers and beds to paying for outputs, right? So they started paying per capita at the primary healthcare level per person. They started paying fee for service. They started paying per case, right? So they started thinking a bit about what are the results we want to achieve in terms of services. Unfortunately, because of budget constraints, Armenia now has one of the highest levels of out-of-pocket payments in the world. 85% of health spending is paid out of pocket. What that means in practice is if I have a healthcare need in Armenia and I don't have money in my pocket, it is very likely that I'll be cut out of needed care, right? And so the need for reforms to the way healthcare is financed were urgent. And like I just said a few minutes ago, there's already an obvious discussion we need to have about the level of public health financing. But there were also discussions that needed to be had about how financing was spent already in the public sector. Why? Because the Ministry of Finance, one of the motivations to spend more money in a sector is that money is already being spent in a way that is productive. That takes us to the discussion on strategic purchasing. How do you purchase in a way that strategically links the allocations, right, that you're making in the health sector to the goals of universal coverage? And so we took a look at these dimensions I described for purchasing, and I'll give a couple of examples, right? So first of all, on what to pay, we looked at the benefit package that Armenia has defined, a package that defines these are the services that the state would pay for. Does this cover the essential services that need to be covered for the population? We found out that for maternal and child health services, infectious disease, the answer is yes. But for many non-communicable diseases, the answer is no for most of the population. It turns out that 93% of deaths in Armenia are due to NCDs, right? So even though they're doing a really good job of covering things like antenatal care, skilled birth attendants, not covering things like, treatment for diabetes, means that a lot of people are shut out of care. So that's an example of what to pay and how, thinking about the content of the benefit package and the cost sharing, how much I'm supposed to pay when I receive services, is affecting access to, essential healthcare of high quality in Armenia. Moving to how to pay, right? Provider payment. Like I explained, Armenia now pays, per capita, right? So at the primary healthcare level, the primary healthcare facility receives a fixed amount per person over a period of time. What incentive does this create? It creates an incentive to conserve cost as much as possible, right? So things like prevention that are lower cost than treatment, right? It creates incentive to do that. Unfortunately, it also creates incentive to over-refer, right? The primary healthcare provider is trying to make a profit. So where possible, he tries to refer or she tries to refer this patient to someone else to bear the cost. And in Armenia, gatekeeping, which should put some regulation between movement between primary healthcare and other services, is not very strongly enforced. What is the result? The result is that you have cases that should be treated at the primary healthcare level being referred to hospitals, and you have high levels of hospitalizations that are unnecessary that are reimbursed through the state. And so by not thinking about the financing or how we are paying across levels coherently, by thinking about it in a segmented way, we lose the opportunity to conserve costs and improve quality, because we know that for non-communicable diseases, primary healthcare should be able to meet your needs 80% of the time, right? And so an over-hospitalization of care for people living with non-communicable diseases, doesn't get us to a situation where people are healthier overall, right? And so far we looked at what to pay, how to pay, and then, maybe I'll talk a bit about from whom to pay, right? And so Armenia has this law that stipulates for you to provide services, you have to have the following. You have to have equipment, you have to have supplies, you have to have a system for financial management appropriately. But in practice, it turns out that some of those things, that you also have to be licensed, it turns out in practice that many of the things are not enforced. For example, licensing and accreditation of facilities stopped sometime in the early 2000s, right? And so while we have a decree that lays out a system for thinking about, does the provider have the capacity to give you services of high quality? In principle, almost everybody is contracted for services, right? And there are practical reasons why this happens. We can talk about it later. But if you take all these things together, you see a situation where, you have an underfunded healthcare system, obviously, because of the high out-of-pocket payments. But even within that 15% or so that the public health sector is allocating, there's room to rethink, the decisions on what we are paying for, how we are paying for it, who we are paying, right? That can improve access to and quality of care in Armenia, and improve financial protection through, the amount of cost sharing that, people have to pay for when they receive services. So I don't know, do you have a follow-up question, or this is relatively clear? I went pretty fast.
Yes, that's a good one. You just mentioned just now, and also in one of the publications you co-authored, about the out-of-pocket in Armenia being over 80%. Hence, in a country like Armenia, purchasing reforms are very necessary and insufficient conditions to progress towards usage. You and your co-authors also rightly stress the reforms to mobilize additional public revenue and reduce out-of-pocket expenditures. So I'd like you to reflect on the Armenian example. Can you speak a bit more about how purchasing reforms be linked with revenue mobilization and pooling, if the goal is to improve access and quality of care in Armenia?
Yeah, that's a really good question, right? So, it's true that I have spent the past 5 minutes talking about purchasing, but without contradicting myself, I'm going to now go back and reflect on revenue raising and pooling, right? So, we have a lot of experience. Some of this is coming out of the World Bank. There was a study on 24 countries that had made progress towards UHC over the past decade, led by Abdul Yazbek. He's now left the bank, but he had done that study, where we looked at the countries who have made progress. What have they done? And there's a critical role not only for how much public financing you have, but how it is raised, right? So in a country like Armenia, if I have a healthcare need, then I have to think about, if I'm not a civil servant or I am not a member of a vulnerable group, then that money has to come out of pocket, right? And so you have high levels of people either forgoing care completely or maybe not seeking care, delaying care, and having complications, and then seeking emergency care that is a lot more expensive, right? So, or catastrophic health expenditure. A person spends so much that they have to go into debt, or they have to, avoid other important expenditure, like maybe for education, for nutrition, right? So, why is this not the right way to raise funds? We know from looking at other countries that if you want to raise funds in a way that's equitable, to tie healthcare use to need rather than ability to pay, what you want to do is to raise those funds before the need for healthcare arises. We call it prepaying, right? So you mobilize those funds, and then the second thing you do is you pool them, right? So we know, for example, there's risk, the individual risk for healthcare is very different across individuals. Intuitively, we know our parents, older, more likely to have chronic diseases, more likely to need care versus the younger person, right? We also know that people who are richer tend to need healthcare less than people who are poorer. So unfortunately, ability to pay is negatively correlated many times with the need for healthcare, right? And so we mobilize those revenues through public financing, and then we pool them. Now, how they're mobilized is important, right? If I'm a healthy person, I'm in my 30s, I barely need a doctor. And you tell me, for the love of everyone who's around you, why don't you nicely contribute to this pool? Chances are I'll say no, right? And so the two things we have found are critical for raising money through prepay to a public pool is one, compulsion, right? They're called Fuchs laws, described by Victor Fuchs in 96 when he was looking over the Clinton reforms, health reforms. Compulsion, meaning everybody should be compelled to contribute, whether you need healthcare now or you don't need healthcare now, you contribute to the pool. But already there's a problem. If you listen to what I'm saying, there's a problem. But what if the person cannot afford to contribute? Then we have the second principle, which is subsidization. For the person who is poor, the person who is vulnerable, who can't afford to contribute, to this pool, then they are subsidized. So the combination of compulsion and subsidization allows us to have a sufficiently large amount of revenue that is collected. And then we come to the second piece, right, which is pooling. And so something we've discovered is that unfortunately in many countries, we start by saying, we're going to have a pool for employed people. All the civil servants we collect from your payroll, and then you have this pool. And then the government takes on, what we call the bad risk. So the people who are poorer, the people who are sicker. And then you have two pools, one in which people are not using a lot of healthcare, that's very rich, that's very generous for the civil servants. Then you have another one that is escalating costs. People constantly need care. The state is bearing a huge burden. Think Medicaid in the US. So what we've discovered is that's not what you want to do. You want to combine good and bad risk so you can cross-subsidize. I don't need healthcare now, but the money I'm putting in the pool can help pay for the healthcare of the person who is older, who is less sort of, has lower income that needs healthcare, right? And so basically, without going into much more detail, in a country like Armenia, the conversations we are having are not just about purchasing, right? We're having conversations also about raising money through mechanisms that accommodate compulsion and subsidization and pooling those resources, and because another reason why pooling is important apart from cross-subsidization is purchasing power. So it links back to purchasing, right? So if you have a purchaser and total amount of money you are spending when you are allocating is 15% of all spending, then you're not such an important player, right? The provider can afford to ignore whatever you're doing. But if you're a purchaser, like in Romania where I work, where 80% of health spending is transmitted through, then you can fix incentives in the system. If you tell providers, I'm paying fee for service, and the amount of money you're spending is 80% of their revenue, then you're more likely to nudge their behavior in the direction that is compatible with progress in the healthcare system. And so, I mean, we could talk a lot more about this, about, how to raise revenue and how to pool, but perhaps I should stop here and turn it back to both of you.
Yeah, so thank you. We now look at NCDs. You mentioned about going NCDs in Armenia and also mostly in many countries. So this is, in fact, particularly more important to developing countries where NCDs are continuing to be a burden in the disease distribution. So I would like to get you to reflect a bit more on the hour of purchasing. That is the provider payment mechanism with a specific challenge in mind, like I said, on non-communicable diseases. In what ways do you think traditional payment method like salaries, capitation, fee for service supports the provision of high quality care for people living with NCDs? What option does a purchaser have to use payment reforms to get providers to deliver the right kind of care?
So that's a really good question. And it's a question that I and like the rest of my team spent a lot of time working on in Romania in 2019. Right? So we came into the country. The government was thinking about reforming primary health care, and the primary motivation for that was that the incentives in the system created by provider payments was totally counter to the sort of needs that people have when they have non-communicable diseases. So let me try and take a step back and explain. So, think about the child who has a fever, right? You have a fever, you have a cough, and you have, this standard, it's called the integrated, management for childhood illnesses. This procedure that we have has been developed by the WHO many years ago. And so you come to a provider, it doesn't matter which provider, and they ask you a couple of questions. They decide you need an antibiotic, do you need painkillers, do you need rest, and you go, right? Now, if the next time you have an illness, you meet this child, sees another provider, chances are that's fine, right? The chances are the two events are not related. Now, contrast that with the person who develops, say, diabetes, right? She's in her 40s, or so, and then, she develops diabetes. Sometimes she might also have hypertension. Over time, she develops complications, right? And so this is not going to be a one-off interaction that she has with healthcare system. She's going to have multiple interactions over the course of her lifetime on different issues, on the complications, on trying to find control for her overall disease, on trying to prevent future complications, and so we have found over time that there is a way the health system needs to be organized for chronic diseases that is very different from what we need for the acute care that you need, for example, in childhood diseases. We call it the 4 C's. They were described by Barbara Starfield at Hopkins many years ago, and they are hold true to this day. The first is that you need strong primary health care that is comprehensive. So very wide scope, like I mentioned before, 80% of the needs for chronic disease dealt with at the primary health care level. And then you need continuity of care. So someone needs to be able to have oversight of all the things this woman is going through, the hypertension, the diabetes, the complications, so that she's not being managed by an endocrinologist for the diabetic foot, the ophthalmologist for the eye, and people are not seeing how the different things tie together. The medications might have interactions, the different ways we think about her exercise, her diet, and all these things have to be integrated. So there has to be continuity across contacts, collaboration across providers, and primary health care should also be the first contact. Now, you now take a step back and think about what are the ways in which the way we pay providers, how do they encourage or discourage this sort of model, right? And so in a country like Romania, we have moved past paying fixed salaries, right? So fixed salary, I think about the time I worked as a house officer, many years ago in Nigeria, and I was paid a fixed salary. Now, there's no incentive to even show up. Nobody checks if you're there, you're not there, whatever you're doing, outside of my intrinsic motivation to do the right thing, and maybe my manager, finding out, my consultant. Basically, you get paid, right? A country like Romania has moved past that. We now pay capitation, meaning a fixed amount per person, and then we pay fee for service for some things, right? And what incentive does this create? Let's reflect on it. Does it support what I just described? Now, capitation incentivizes cost containment. You pay a fixed amount, I want to spend as little as possible. So the provider is really thinking about prevention. But unfortunately, it doesn't incentivize comprehensiveness, right? So as much as possible, he wants to refer. And unfortunately, we are paying using case-based payments at the hospital level for some things that can be treated at the primary healthcare level. And so in Romania, lots of things that can be treated at the primary healthcare level are instead treated at the hospital level, right? And then we have the fee for service. For some of the healthcare needs, we pay a fixed fee for service. And for those specific things, there's an escalation of supply because, it's just mechanical. If I produce 10 times X, 20 times X. And then we tried to course correct for that. And we added a cap. So we said, okay, there's a cap beyond which you can't go above. Unfortunately, the level at which we fixed that cap was such that we were undersupplying case management. And case management is the role in which the primary healthcare provider takes the leadership, is the first person of contact, and is trying to navigate between all the providers that are taking care of this person to make sure there's coordination. And so just in this short sort of spiel, you already see how the ways in which we are financing, we are paying providers, is incentivizing them to do the opposite of what we know they need to do for NCDs, right? And so what are the options? We found that for countries, there are two sort of things. So the first is combining provider payment mechanisms. So in most OECD countries, which are a bit further ahead in terms of thinking about how to pay, it is very rare. I think there was a study that looked at the 30-something or odd countries, in the OECD, and only 9 of them were paying at the primary healthcare level with only one payment mechanism. The combination of payment mechanisms allows you to balance the pros and cons of each, right? For example, you pay per case, and then you put a global budget that caps it so that people don't escalate costs, right? You pay a fee for service, and then you put a threshold. You pay capitation, and then for some things you pay fee for service, or you pay performance-based financing to try and increase supply of specific services. But there is also entirely new methods that we are discovering that I think are unique in the way they think beyond the individual provider to the continuum of care, right? A classic example here is what I would call bundled payments, right? So instead of saying we're going to pay the primary healthcare provider a capitation and we're going to pay the hospital a case-based payment, we say that when a person with diabetes needs care, we're going to bundle a specific amount of payment across a group of providers. It forces them to collaborate, right? So already you're inbuilding incentive for collaboration. And because primary healthcare tends to be cheaper to provide than hospital care, because the specialist care labor costs are higher, for example, it also incentivizes a focus on primary healthcare rather than hospital care, right? And so that's another example is population-based payments, where you go beyond an episode of care. And it's like you think about capitation, payment per person, but you do that across a group of providers, right? So you have a primary healthcare provider, a hospital, the entire referral network, and you say for the entire year, this is how much money you're going to get. We could restrict to a disease, or we say for all the healthcare needs. And the incentive, we tell them all the money you save, you can keep, right? So this is the idea behind something like the accountable care organizations in the US and in Germany. And then you can add little bits incentives here and there. So monitor for quality, for example, so that they don't, in trying to reduce costs, reduce quality. But so we're still sort of testing out some of these models, evaluating them. But I think the logic behind them is more in line with the kinds of things that we hope to see for people living with non-communicable diseases than the traditional methods like fee for service or capitation, or God forbid salaries, that we used to pay in the past.
That's definitely very enlightening. Like I'm sitting here thinking of all the different times we've talked about fragmented health systems versus quality of health systems and how these different payment mechanisms can swing one way or the other. Before we move to the next set of questions we had, there's an audience question that came up about the issue of compulsion that you mentioned earlier. And it's kind of like just basically spoke to what I was thinking. So the question from David Ja says, the issue with compulsion is trust and the mechanism used. What are the incentives for compulsion? So the real challenge is how well do we structure public-private partnerships to create incentives?
No, so that's a really good question, right? So when I think about the ways in which countries mobilize revenues and defining compulsion, maybe I should give practical examples to explain how this happens. So in most countries, this is through general government revenue. Think about the tax you pay every day to the states, right? So this could be, let's not say income tax because that's problematic. We can talk about social health insurance, but think about the general tax, say VAT. Some countries in Africa have started, using VAT, like Ghana, tax on mobile phone usage, etc. Right? And so that's not it's a tax you have to pay by virtue of, say, using a good or a service, right? So in a way, it is compulsive, right? You have to pay that tax. right? And then that allows us to now pool resources in the general government budget and then allocate some of those things to health, right? But there have also been examples where countries have had health-specific taxes raised and have had to compel, right? So two examples to raise here are Rwanda and China, which are two of the only situations where we've seen what they call voluntary, but it's quasi-compulsory, where they say you have to contribute to the following pot that is going to support healthcare. And there, I find that what was the driving force behind the mobilization of significant resource was the authority of the state. It's a command control environment, right? And so, these are two sort of models. So on the one hand, you have general revenue, the normal tax that you pay. So we're calling it compulsive, but the idea behind compulsion there is that by accessing that good or that service or that basis for receiving tax, you have to pay the tax. The tax is just a premium on that service, right? And then the second is this sort of, it's quasi-compulsory, it's linked to health, but here you have a state that by virtue of the mechanisms it has, it's unique. The Chinese state and the Rwandan state are unique in their ability to enforce, taxes. Now, the third mechanism that I think where the whole discussion around trust, and incentives becomes a bit difficult is payroll. The example of social health insurance, right? So here, you have a tax that is levied, for example, on income. The tax is directed specifically at funding healthcare. Entitlements are tied to your contribution. So it leaves out everybody else who is not contributing, right? And in many low and middle income countries, you have a high informal sector. So, it's a very small proportion of the population that is contributing this money and is entitled, right, to receive these funds. I would say here, one of the political advantages of this mechanism has been the fact that it strengthens trust between whoever is contributing and the state, right? You can see the connection. I contributed this amount of money, and by virtue of my contribution, I have health care, right? So the state's individual sort of contract is very clear, right? The disadvantage, of course, is that you have all these people who cannot contribute, by virtue of their unemployment or their informal employment, we can't see them, and who, are not covered through this mechanism, all right? And so there's this very interesting article that was written by Abdo Yazbek and all on labor tax finance, insurance, which I highly recommend, talking about the downsides of financing that way, right? So having said all this, to come back to David's comment, I would say that, the discussion around trust is really important. If you're mobilizing through general revenue, it's not something that's as salient. I think when you're having discussions about, mobilizing specifically for health, then there has to be, this is something that if you don't have public support for, and you don't have the kind of command control mechanisms that you have in Rwanda or China, it's probably really difficult to do. And then, on the payroll side, not a model that is compatible with many of our countries with a high informal sector. In terms of public-private partnerships, something that we have learned, in terms of, how to mobilize revenue is that, you can have, hypothetically, a private sort of, agency responsible for pooling etc. But, the for-profit sort of incentive, when it comes to purchasing, I think it makes it a bit tricky in terms of, providing access to high-quality care is something we can talk about in more detail. I hope that answers your question. Please send a follow-up if it does not. Yes, back to you, Maimuna.
So the perfect segue back to that concept of universal healthcare is our next question. At the core of definition of universal healthcare is the idea of universal access to essential services. And this points to the what and for whom of purchasing. So the what points to the challenging process of benefit package design, like you had mentioned earlier. So you had recently published a paper exploring how to optimize resource allocation to benefit packages by considering financial protection, really significantly reducing catastrophic out-of-pocket expenditure, the disease burden, and equity. So what would you say the principles for designing benefits, what would you say are the principles of designing benefit packages to facilitate universal healthcare coverage?
Yeah, so that's a very good question. I think benefits package design is at the heart of universal health coverage discussion, right? So we define universal coverage as having access to essential services. Every country has to have a conversation about what does essential services mean. Making that explicit is really important. Why? Because we don't make it explicit, it's implicit, right? So if we say hypothetically, and a lot of countries have done this, I say, every service is covered for everyone and we don't have the budget. What happens in practice? It means the person who gets care is the person maybe who's closer to the facility, the person in front of the long waiting lines that form, the person who has the resources in terms of informal payments, right? Because we won't have enough resources to cover all the healthcare service for everyone. And so maybe on the side, the primary healthcare provider says, I can't provide the service, unless you provide a little bit on the side for me. And so making benefits implicit, in the end is rationing, right? And so one of the first steps that most countries take towards universal coverage is saying, let us define clearly, based on what are the priorities in our country, what services to cover. Right? And that we put in what we call a benefits package. And so what have we learned about how to do this well? And small caveat here, and shameless plug to a paper that I published is titled Strategic Purchasing for Better Health in Armenia. It has entire chapter that walks through all the global examples for things like benefit package, provider payment. So that's where you can see the detail, right? But let me go back and sort of try and summarize. So what have we learned about how to do this well? I would say the first thing is to be objective, right? So we think about Armenia in the late 90s when the first benefit package was designed. They looked at things like the burden of disease. What are the main things that are causing morbidity and mortality in the population? What do the interventions to address these diseases, what do they cost? How effective are they? So clinical effectiveness, how cost effective are they? And what is the impact on our budget of covering these? And there was a whole set of stakeholder consultations, analysis, a back and forth to finally arrive at this is what the state will cover. That did leave out some things, but included things that responded to the main needs in the population, right? So out of that come, things like the principle of being objective, having technical assessments that inform your understanding along specific criteria, hopefully putting legal documents, right? You want a clear process because there'll be winners and losers. So the clearer and more transparent this process is for these are the factors we are considering, this is an analysis we are doing, the better. And there are many great examples of this. In Thailand, that's a really good example of a clear benefit package revision process. Ethiopia recently undertook a revision of the benefit package that was very structured. They published a paper, I think it's in Nature or Science, outlining what it is. So we have examples, in Asia, in Africa, in Europe, we have examples. In Korea, we have a very good example of not just having a structured process, but a long, stakeholder consultation. So everyone feels like their voice has been heard and a process for, addressing disagreements, right? So you have objectivity, you have consultation, so it's not captured politically, and you have these consultations should be as inclusive as possible. And if possible, this whole process should have legal backing, right? Why is this important? Because the wonderful example that I explained about Armenia became undercut a few years later because you had a new Minister of Health who had different opinions about how a benefit package should be formed. You have a strong lobby group, who can say we want it to go this way or that way. And now we have multiple packages in one, a very nice, generous package for civil servants, another nice, but a bit less generous package for vulnerable groups. And then this other package that leaves out most things for the rest of the population, right? And I think part of that has been just the, difficulty in terms of raising funds, to cover everything for everyone. But part of it has also been, you don't have a process that's objective, that is defined with clear criteria, that is enshrined in legal documents and protected. And so it becomes a process that can be captured by whoever is powerful, by whoever's whim. I think the following should be covered, therefore it should be covered, right? And so in the report that we published, we used what is called the HIP tool, the Health Interventions Prioritization Tool, to reflect on if we were to optimize the current benefit package in Armenia for the burden of this, to meet the burden of disease, to consider cost effectiveness, and to consider financial protection, right? To consider what services do you pay for and it is catastrophic. What kind of benefit package would we be looking at? And we found out that it's a bit different from the current benefit package. We would increase some of the allocations that we have for NCDs, we would decrease for some other services. Some services that are currently covered would not be covered if our aim were to maximize, health in the population and to conserve budget as much as possible, right? But every country has to decide what matters to them. Cost effectiveness will matter to one country, burden to another, equity to another. But if the goal is universal health coverage, then in a sense, the goals have been defined for us, right? It's universality, it is access, and access, part of that is financial protection. It's making sure that everybody can access services without, being exposed to financial risk. And so I think those would be sort of my broad sort of, takeaways on, the things that matter for designing benefits consistent with universal health coverage.
That's a great response. And previously you had mentioned, countries that have universal, at least significant universal health coverage, like Rwanda with their mutual. The UK is known to be the model for, single payer system and universal health coverage, but yet it's fraught with its own challenges. One of our audience questions, and this is quite broad, so feel free to just respond with a specific field, is how has the NHS in the UK sustained itself? Sure, that's a loaded question.
It is a loaded question. I wouldn't consider myself an expert in the NHS, but I will try and sort of discuss what I know about that system. So the NHS by design is funded through general revenue, right? So it's not social health insurance, it's general revenue that is pooled, that funds health service delivery. Over time, because this is a system that is built on the public sector, they've done a lot of thinking about how do we make sure we also have incentives with this monopsony single purchaser to have efficiency, right? And so things like competition, mechanism for competition, performance-based financing, for example, have been incorporated into the system. But the system is not without flaws, right? So the fact that you have a government system covering most things for most people, has brought in some other things. For example, there's a lot of complaints about the long waiting lines in the NHS, for example, right? And I'm sure that the burden of paying for this healthcare is probably escalating, right? So this, even if it's general revenue, it is coming at a significant cost to the budget to cover this, the cost of this system, right? And so, how does, in a high income country, this is not as much of a problem as it would be in another country. How does a system like that sustain itself financially? It is through the principles that we've discussed before. We go back to basics. When everybody is contributing, compulsion, right? It's not a few people in the population that are contributing payroll taxes and it's covering everybody. Everyone is contributing. We either collect, from the entire population through payroll, as in Germany, or through general revenue. And we subsidize people who cannot contribute. That is how you build a system that is able to financially continue to cover significant amounts of care for the entire population. But like we discussed, it is not enough to mobilize significant revenue. You have to intentionally reflect on the ways in which you allocate resources that conserve finance. One really important thing to point out about the NHS is NICE, the National Institute for Clinical Excellence. The way in which the UK defines what services they cover or not is they have an institute that assesses what is the relative cost effectiveness, the value for money for covering this service for the population. And we have a threshold below which we will cover, above which we will not. And over time, they have refined that process, right? So I recently, was forwarded a document where NICE is now beginning to look again at this process and saying, what else do we need to factor in apart from cost effectiveness? Do we need to think about equity? Do we need to think about other things? So that when we are providing recommendations for what we cover or not, it is informed by not just cost effectiveness, by all these other factors, right? So to take a step back, I think there are a couple of reasons why the system is sustainable. One is the basic principles of compulsion and subsidization in a high-income country where there are significant revenues, right? But two, it is also intentional mechanisms that are built into the system to improve efficiency. Things like, the NICE and the way they're thinking about health services, and the innovative payment mechanisms like performance-based financing, other ways you think about how do we pay for services consistent with our objectives, right? But, the system is not perfect. We at least know about the waiting lines, and we know that the reasons why they keep going back and forth on the way they pay, on who they pay, is because, they're trying to address challenges that come up. But I would say strategic purchasing, the way to think about purchasing is, it's almost like it's a process that keeps being iterative and adaptive, right? No country purchases strategically 100%. There was this recent paper written by Klasser et al. On some of the most advanced systems, so France, Germany. And the conclusion of that paper is that even in those systems, there were many opportunities to make purchasing more strategic, right? And so ideally, you're not just one time setting up a way for collecting revenue and for purchasing. You're also embedding processes for learning through collecting information about what is working and what is not working, and refining in line with the goals that you have for the system, right? And so implicitly in what I'm saying, you have some purchaser that is over the system that is making these decisions, right? We can talk later about what happens when you have a bunch of different people trying to figure this out, what's the implication for the system. Yes.
Yes. So that's very good. One of the things you mentioned earlier is that, and also in your publications, we have a very varied environment when it comes to providers, the public, the private, those with very good quality and those that are not so up there, and those that are big and those that are small, and those that are probably urban and those that are in rural areas. And it's quite a complicated distribution of providers. And so one important function you mentioned in your book is which providers are responsible for service provision. And in the Armenian publication, you note that with that such kind of distribution of providers, right? We'd like you to talk us in more details about the role that selective contracting, right, in improving healthcare, and why is it an option, is not viable in the Armenian context in selecting different providers to be able to offer these benefits packages and the sort of quality of care that we sought after.
Thanks for the question. Selective contracting is one of those aspects of purchasing where, theoretically, it should be fantastic to do, but in practice, it's quite difficult to do. And sometimes, the trade-offs make it not worth doing, and I think the Armenian example really explains. So in selective contracting, what do? We're selecting providers, right? And we want to select providers that can, deliver services of a certain level of quality. So we specify, what does quality mean? We specify it structurally. What inputs do you need to have? What personnel do you need to have? What equipment? What systems? You specify it through processes, right? So we can say things like, you have to provide the following within clinical interactions. If we don't see this historically, that you're providing this level of care in line with guidelines, then we are not going to contract you. We can define quality by outcomes as well. So we say, okay, people who have had a high level of readmissions for things that you shouldn't be readmitted, or mortality following hospitalizations that is preventable, then we won't contract those providers, right? So different dimensions. In practice, most of the cases where we see, payment or ways in which we are contracting and including quality, we tend to use structure because it's easier. It's easier to count things, people and inputs or systems, or a bit harder to look at compliance with guidelines, and very difficult to figure out outcomes, right? So I think I've only seen, recently there was this review and there was this example from Kyrgyz where they were looking at patient satisfaction as, something that they were considering in terms of quality. And so hypothetically, we have these indicators for quality, we specify them, and then we say which providers fit, these providers can provide that service, can provide services, and the ones who don't, do not, right? Sometimes we can also segment. We can say the provider demonstrates the capability to provide the following services, but not the others, right? And so it's not that it has to be all or none. It can also be segmented across different kinds of services, even within, say, primary care or hospital care. Now, in practice, we all know that, I work in environments where access is an issue, right? So special distribution of providers we have for different reasons. It's either we're not training enough doctors and nurses and other kinds of health workers, or they're emigrating, or the spatial distribution is such that you have one provider serving the entire community. So in practice, if you decide, because X provider does not have equipment, does not have XYZ, we will not contract the provider, you are in essence dooming the entire population to not receiving care. And so this is something that we see is a legacy of the post-Soviet state in Armenia. We have the distribution of providers was such that there were special monopolies intentionally set up. You have a provider, he has a catchment area, and he's just the only one there, right? It's a rural ambulatory, it's a primary care facility, and around it are all these people who receive care there. And basically there's no other option, right? And so while in theory, there's a very clear, like I explained, a decree laying out these are the following characteristics you should have. You should have the following equipment, the following personnel, you should be licensed, you should have financial management information systems, etc. In practice, 100%, almost 100% of public providers are contracted to provide services, because excluding any provider who is in outside, say, the capital, where you have overlaps of catchment areas, means that you're excluding people from care. And I find that this is common. It's not just an Armenian, it's not unique to Armenia. It's something that I've seen in a lot of other countries. And so we have to reflect on, so what are your options, right? You don't also want to create a situation where the incentive you're giving to providers is that regardless of what you do, you shall be contracted, right? And so the kinds of things that we are considering now are, can you change the management of facility? Can you coach the management to improve the quality of care? Can you encourage new entrants into the market, right? So things like that. Sometimes this latter suggestion might not work in practice because you just don't have enough demand for an additional entrant to come into the market. So just to say, this is one of the examples where, in theory, fantastic idea to selectively contract. In practice, very difficult to do, and I'm still on the lookout for good examples of countries that have done this, where they have their spatial monopolies in the distribution of providers.
Yeah, that's great. So one of the very important things also with strategic purchasing is data, the issue of data. And as we know, data is a big challenge, especially for developing countries and that don't have the infrastructure. So the next questions, I would like to focus on that. So like I said, most scholars think data is very important to strategic purchasing and to align the decision of purchasing to the goals of UHC and the eventual impact they would have. So in the absence of pre-existing sophisticated electronic health management information system, can countries purchase health services strategically? Is it really possible for countries to be able to purchase strategically with the data deficiencies that exist?
So the short answer is yes, but I don't think I should leave it there because I'm sure there are people that be like, oh, that doesn't sound right. So let me explain. So ideally with strategic purchasing, you're paying, you have a contract that lays out the obligations of the purchaser, the person paying for services, and the provider in terms of what services they're providing, how they should provide the services, etc. And you're collecting data, right? So you're collecting data usually by virtue of that payment mechanism. This is the ideal situation, right? So if it's per capita, on the number of people who are enrolled, if it's fee for service, all the services that are claimed, maybe also collecting data on the standards of services. You're checking boxes on was the following done, was the following not done, etc. You're collecting financial data. And maybe you're also getting data on the diagnosis. It's giving you a sense of what are the needs in the population, what are the things that we are seeing more of and less of, and how does that affect what I pay for or not, right? So the combination of information on the healthcare needs in the population, what the provider is doing, is what you now sort of aggregate to now sort of refine, the contracting provisions, how you're selecting providers, how you're paying them to try and meet those needs. In practice, in many countries, when a discussion on purchasing is starting, the system that you have cannot support, data collection at that level, right? And you don't have to look too far for examples. First of all, in many African countries, we have piloted performance-based financing over the past decade under the Health Results Innovation Trust Fund. When we started in many of those countries, there was no HMIS, right? We were just beginning to look at DHIS2 starting, right? So what happened? We find that there can be a virtuous cycle between purchasing and data, right? The fact that you are introducing purchasing and there's resources to introduce purchasing can be an incentive for data systems to be developed. An example that I go to often is Plan Nacer in Argentina. We talk about that example in the report I talked about, strategic purchasing for better health in Armenia. So, the country decided we're going to introduce incentives for maternal and child healthcare services through performance-based financing. And so they do at baseline, at design stage, an assessment of all the provinces. Do we have systems to collect data on all these maternal and child health services to tell us services were produced or not, were delivered or not, which is now the basis for paying? The answer was no in many cases. So what did they do? Now, they didn't do something that many other countries do, which I think is wrong, right? So you go and you say, this very nice software, everybody must buy and install, right? Regardless of whether your system is able to do it or not, whether you have the software, whether you have people who can do it. So you by trying to solve the problem through a centralized, software that is proprietary, usually there's one agency that is brought in, you create new problems, new costs for this facility, new issues in terms of, have we dealt with the data privacy, data use, new concerns, etc. What they did was specify, this is the data we want to collect. You can provide the data by paper or electronically, just in a standard way. Progressively, we want you to move to an electronic system. You choose the software. The software has to be interoperable with the software in the center. So it doesn't matter what you choose, just make it interoperable. And then here is technical assistance at the central level, just in case you need help. And over time, they started with paper-based billing, but slowly but surely, the incentives were created. Why? Because after month 1, month 2, you see, if I report maternal and healthcare services provided in a way that is standard, resources flow to me. The resources that flow are incentive to set up the systems that need to be set up for me to receive more resources, right? And now, over time, across all the provinces, they have different health information systems that have been set up, and now they're having conversations about how do we make sure they're all interoperable with each other, right? So I think that's a really good example of how the growth in a health information system can be organic, right? And another example that we can point to is, diagnosis-related groups, right? So usually when we think of DRGs, very complicated, costs for specific cases, different micro-diagnoses, not diabetes, it's type 2 diabetes with nephropathy of the following type, right? That kind of thing. And because we're thinking of the cost structure. Now, when I think it was Kyrgyz that was launching diagnosis-related groups, they knew they didn't have the systems for that. So how did they define the groups? By department level, like the clinical department. That is where they started. If cases are within X department, nephrology, this is the average cost. And then as the data, the richness of the data started improving, then they started disaggregating further, right? And so the principles here around, one, the match between the sophistication of the health information system and the purchasing mechanism used, right? So we can start purchasing strategically, even if we have just paper-based systems, right? But there's also a conversation there about iterating and growing. So over time, as we learn, right, and as the incentives in the system are set, then it opens the door for you to increase the sophistication of that system as well. But I think there's a third and a fourth principle on interoperability, right? So, the idea of a centralized system is not something that we recommend, but a system that allows the different software to talk with each other so that you have the purchaser at the center can draw intelligence and insights from all these things is really important, right? So even if you allow decentralization, this has to be some sort of interoperability. And then once you have data moving up and down, the last principle, data privacy. Serious conversations about what happens to patients' data, who can see it, who can use it, how do we protect this data and are still able to use it. So, I'm leaving a lot of questions on the table, but again, referring everyone to the report that we wrote on strategic purchasing, where there's a more detailed discussion of these issues. But thanks again for the question.
I'm glad you mentioned the report, Adanna. So we would share those resources with our audience at the end of this. For anyone just joining us, you're welcome to today's episode of Public Health in Real Life, where we have the delightful Adanna Chukwuma, a senior health specialist at the World Bank, speaking with us about paying for universal health coverage, the what, why, how, and for whom. We are close to the 1 hour mark now, but we have a lot of audience questions that I want to get to. But before then, it would be remiss if we don't talk about COVID-19 and financing and health systems. So, it's very clear at this point, the ways in which purchasing reforms can support universal health coverage just based on the responses and, the very riveting conversation we've had so far. But as you know, we're in the middle of the COVID-19 pandemic. You're part of a global team that, hosted on a collectivity platform, and you guys examined how purchasing arrangements enabled countries to respond to health needs during the COVID-19 pandemic. What are some examples of changes in purchasing arrangements that countries have made, and how have these changes contributed to the COVID-19 response?
So that's a really good question, Maimuna, and it will probably take a lot more time than we have to answer it. So let me try and do a quick take. So the COVID pandemic struck, and I think for many across the world, purchasers were faced with at least two critical questions: how do we maintain access to essential care for non-COVID-19 cases? And then secondly, how do we ensure access to high quality care as well for COVID-19 cases, right? And so this is the challenge that purchasing had to respond to. And along the different dimensions that I had mentioned before, different countries have tried to address these questions, right? So first of all, the question of what to purchase, right? So in many countries, including in Armenia, including Romania, we see an expansion of the benefit package, right? So the benefit package was expanded to include, first of all, for COVID, the COVID-19 care, case management, maybe at the primary healthcare level for mild and moderate cases, and in hospitals for severe cases, right? So it was added to the contract for providers. We are going to reimburse you for the following services to encourage the use of care for those services and testing as well. And for non-COVID-19 care, new mechanisms were added. So I think in Armenia, teleconsultations was now something that could be reimbursed through the state. Also in Romania, teleconsultations, because the state was trying to make sure there was not incentive for people to keep moving around, right, and spreading disease. So compatible with the lockdowns had to be a new mechanism for ensuring that we minimize disruptions. So, right, so that's on what to pay for. On who are we paying for services? We don't see as much that, private healthcare providers are providing services. It was mostly the public sector. However, in some countries, there was a specification of what are the standards that need to be met for a provider to provide these services, right? So in Armenia, for example, 1,700 or so beds were identified in 9 or so hospitals. Hospitals that met certain standards were able to provide oxygenation, ventilation, all the kinds of care that you need for hospitalization of cases, right? So in specifying who would provide those services, that's a purchasing function. The government intentionally was trying to define that to ensure that high quality was guaranteed for those cases, right? And then we go to how to pay. New mechanisms for payment were introduced. Why? In both Armenia and Romania, at the hospital level, you are paid by outputs. Per case that you have case-based payments. So you have more cases, you have more payment. When you have a lockdown and people can't receive care, your hospitals can go bankrupt. And so quickly in both countries, they had to think about how do we pay differently to sustain these hospitals financially, even if they are not meeting their output targets. For example, global budgets. So prospectively, a fixed amount informed by historically the output in terms of cases was introduced in Romania, for example, and given to hospital. It was capped at what was historical, but not capped for COVID-19 care, because here it couldn't be informed by historical sort of data, right? Mm-hmm. And then in Armenia, for example, in addition to the capitation at the primary healthcare level, a bonus was introduced for health workers, right? How do you get health workers to be incentivized to come to hospitals and provide this care? They introduced a bonus, right? And so you already see how countries were thinking systematically about what incentives do we want to create to provide healthcare for COVID-19, to provide care, essential healthcare, and changing what they were paying for, how they were paying, who they were paying, and I would say who is making the decision. So even in the governance of purchasing, that changed significantly. In most countries, it was escalated. It was no longer the Health Insurance Fund or the Ministry of Health. In Armenia, a deputy prime minister was leading a multi-sectoral effort that included a section on health, and decisions, even on purchasing, were made at a very high level, right? And so, on every single dimension of purchasing, we see how this lever was critical to the purchasing response, right? And so this study is ongoing. We haven't, finished it yet. We're going to try and look at, so how did providers respond to all these changes in purchasing? And then what was the end impact? Did it change utilization experience? Did it change quality of care? Did it change financial protection? And hopefully in a year or so, the results will be out and we can all learn, for future pandemics, the ways in which purchasing is a useful tool, whether we are responding in terms of universal health coverage or we are responding to a virus like we did for COVID-19.
It's interesting how you mentioned, the systems being nimble and flexible to respond to COVID, which takes me back to the point you mentioned earlier about strategic purchasing, that it's not just a one-time thing. It has to be flexible based on needs. So I'm glad at least you were able to, explain one of those examples come to life. So we'll take a few audience questions now because we're way past that. We're past the hour. This is from Sabine Bernard. What are your views on innovative, and please feel free to just answer briefly and, we'll share resources at the end. What are your views on innovative financing models using private sector investments to help fill the gaps in a health system reliant on out-of-pocket spending?
It's a good question, Sabine. Thanks for the question. So, what I will say is will be informed by empirically, what have we learned? What we have learned from looking across countries that have achieved universal health coverage or made significant progress towards universal health coverage is that the predominant source of financing tends to be public, right? Because like I described, these principles behind how revenue is mobilized, compulsion, subsidization, right? Because private sector financing usually seeking profit. When you have a large proportion of people unable to pay and with huge healthcare needs, right? Then the for-profit incentive is very difficult to meet that, right? And so this is usually a place where you need state intervention. The failures in healthcare markets, the fact that you don't have enough information at individual level to make the decisions, you might not have enough money to meet your own needs. This is why it's a classic example of where the state needs to step in and try and address these market failures. And what we've learned, by looking across countries, both the first generation, we're looking at Europe and the countries that moved first in terms of universal coverage, UK, Germany, France, and the later examples, I highly recommend Going Universal, the book by Abdo Yazbek et al. What we are learning is that, public mobilizing revenue through public sources using compulsion, subsidizing the poor is the predominant way to raise money for universal health coverage. That being said, there is room for innovation, right? Maybe just not what we are thinking about. Like I like pointing to Ghana. Ghana has, through value added VAT, has, I think it was a VAT of 2% or so, significantly financed universal health coverage, expansion of coverage, and other reforms to try and make sure that everyone has access to high quality care. We have Philippines and a couple of other countries that use excise taxes on tobacco, not just to reduce demand for tobacco, but also to raise revenues that are used for healthcare. So can we think, smartly? I think there's also a mobile phone tax, perhaps in Ghana as well. So we can think smartly about the ways in which to mobilize revenue through public sources. But I think once we start having conversations with private investors that have a for-profit motive, then we need to think carefully about where they come in. It's not clear to me that where they come in is on the revenue mobilization side. There are other opportunities to engage the public-private sector. For example, in the management of institutions that allocate resources, right? That is an example. Or to invest in standalone, like huge hospitals, tertiary hospitals. There might be models there compatible with, the for-profit incentive of a private investor. But for raising funds for universal health coverage, but, there, I think, the lessons are clear of this very important role for public revenue and for financing UHC.
That's great. So there's a question which I think is basically a follow-up to what we just asked from Natasha Banya. It says, can all the different ways of mobilizing revenue be utilized by a country, like some low-income African countries? If so, do you have a model that worked?
It's a really good question. So I sort of started on this point a few minutes ago, but I didn't really land to have an opportunity to go back. So I think, it's one model that has been touted a lot. I think, we go to many countries and there's a conversation about UHC, and immediately, all of a sudden, we start hearing words like social health insurance being, thrown around. And I think we should take a bit of time to talk about why that model might not be the right model for our countries. And I think it will hark back to the point you brought up before about what are the ways to raise money, right? So, social health insurance, like I described before, you raise money through payroll tax, you earmark it, you say this is for health, so you ring fence it, and you say it's for health. And entitlements, meaning your ability to access healthcare, is tied to the contribution to that fund. Now, why are people, touting this? Why is this something that, ministers are really excited about? Some ministers, they're like, yes, we're going to universal coverage through social health insurance. Why is this exciting? Ring fencing is exciting to a minister who is struggling every year to make the case to the Minister of Finance, I need money. All of a sudden, you have this amount of money and it's cordoned off, and it's put inside this bucket and it's yours to spend. Sometimes it's also shielded away from the broader public financial management rules, right? So we've talked a lot here about, fee-for-service capitation. Sometimes you have a country where things have to fund inputs, they have to fund labor, they have to fund capital. And when the money is not cordoned off, then you cannot introduce some of these innovative financing mechanisms. So that's the second thing. Thirdly, it's trust, right? So I am contributing and I can see my entitlement is to services is connected to my contribution. So politically, it can be very easy to get this through. It can be, if entitlement is truly linked to contribution. However, in practice, why does this model not work for our countries? One, the size of the informal sector. Now, in many of our countries, over 50% of people, we don't see their salaries. We don't know how much they earn. We can't track it, and it's very volatile, their earning. It's not a fixed salary. It's not going to any bank. And so, the tax base for something like payroll tax is very narrow. It's relatively narrow. Say, countries compared to countries like France or Germany, where they have high levels of formality. Also, the ways in which countries are growing now is different. It used to be you grow, you become industrialized, people become more formal. And so we'll start with social health insurance, and broadly, as we go over time, people will become formalized. Unfortunately, with global value chains, your country can be growing, and all you're doing is producing a screw that goes into this vehicle, and all the parts were produced across the world. So the pathway for growth has changed and suggests we might not be moving towards a situation where we have more and more people in the formal sector in the short term, right? And then thirdly, you're cordoning off these resources, and many ministers of finance, they don't like that. Why? This year is a classic example. You have a COVID-19 pandemic. You have a part of your budget that you can't touch because it's earmarked. And so the flexibility to move back and forth is not there. And so you have inefficiencies built into the system, right? So there are a couple of reasons why this method is not a method that for raising funds that is compatible with most of the countries that I work in. What have we found that works in practice that has the principles I described of compulsion and subsidization? Is general government revenue. Is taxing things like consumption. Most low and middle income countries that are raising funds for healthcare have raised it through taxing consumption. It's things like VAT. It's things like excise tax. Not income, because like we described, it's not payroll income because we have small formal sectors, but you can tax other kinds of income, like real estate, right? For example, right? So basically, the summary is think general government revenue, think consumption tax. If you're thinking income, don't think payroll tax. Would be my short answer here to that question.
That's definitely a very interesting summary. And I think to just buttress with data, on the average, McKinsey and a couple of other people did a report and said about in some countries in sub-Saharan Africa, more than 80% of the sector is informal. Yet conversely, you have greater than 60 to 70% of mobile phone usage. So that's a converse. So you can definitely flip that script to working on consumption tax to generate revenue, as in just payroll and income taxes. So they're definitely very interesting perspective there. There's a question for Kumrul Hassan, which is, again, one of those very broad questions, but I think he would just love to hear your own thoughts on it. He says, I'm curious about how healthcare systems performed during COVID-19. Could you please comment where healthcare systems came short and what can be done to prepare for the next pandemic?
Oh my, that is a loaded question. I don't even know where can I begin to answer. Well, thank you for the question first, Kwamro. So I think to answer that question, you have to first reflect on what did we need healthcare systems to do, and then now reflect on what did they do related to what we needed them to do, right? So we needed our healthcare systems to prevent, first of all, the pandemic, to detect cases early, to follow up those cases, to follow up their contacts, to follow up those cases, right? And so how well did we do on these dimensions? First, on prevention. Now, to prevent, we would have needed to set up mechanisms that allow us to quickly find out if a person comes into the country with a case, shut it down to reduce, the spread of the disease. We'd have to do very well at contact tracing and, quarantining and isolation, right? To detect, then we need to ramp up testing facilities, right? So we need all to have PCRs for testing. We have to have figured out what are the questions to ask when we are screening people, who gets a follow-up test and when. And to follow up, we have to decide in terms of treatment, who gets treated where? What is a mild case? What's a moderate case? What's a severe case? Where did they get treated? How well have we done? I think across the world, we can agree that we didn't do very well at preventing. I think that it took a while before, because we're learning by doing, it took a while before we figured out, what do we do here to stop the spread of this virus? What do we do to make sure that it doesn't become community transmission? But when we did discover very good information coming out of, for example, the World Bank showed that countries that introduced restrictions in movement, severe restrictions in movement, suffered less in terms of the spread of the disease, suffered less in terms of the economy, right? So I would say we had a slow start in terms of preventing spread, but when we eventually learned as a globe what to do, we have many good examples, including in Africa, including in Europe, across the world. It wasn't about income. It was about the politics of making decisions, right? How fast can we make decisions about slowing the spread of the virus by locking down, by introducing masks and enforcing that, by introducing sanitation and enforcing that, by introducing social distancing, right? And so the prevention bit started slow, ramped up. On the detection bit, I would say here the big constraint was supply chains. Unfortunately, our basest instincts kicked in once the COVID-19 pandemic came, and then the rich countries bought up most things, and the poor countries were scrambling for where are we going to get test kits, where are we going to get this, where are we going to get that. So I would say that on testing, supply chains were the main constraint initially. How can we secure enough reagents, enough PCR machines, etc. to test, and so some countries were using tests that maybe might not perform as well, as the PCR tests, so I would say, supply chains, funds were an initial constraint here. But like, prevention, we eventually learned, and supply chains eventually eased up. And in the beginning, when we couldn't test, we test using PCR, we adapted, right? So in many of the countries I worked in, there were questionnaires, there was all this thing around linking, contact tracing, people were innovative. Suddenly, countries that had community health workers found themselves at an advantage. You had networks in the community to quickly find out and map who had contact with who. We also had, in more sophisticated ends, for example, in South Korea, mobile phones and tracing who was close to who, right? So that even if you're not able to test specifically, you can map out, we are preventing, we can map out how do we detect who is likely to have, this virus, and get a handle on it. In terms of now treating, right? So this person already has disease and is treated. I think here that, especially due to the leadership of WHO, a lot of countries did pretty well, right? We had guidelines coming out very quickly on what is the equipment you need. We were learning. Initially, we thought we needed ventilators. We found out, no, the settings are not right. So we need oxygen. So I think that WHO played a leadership role in defining what equipment you need, what human resource do you need, what are the options for mobilizing, how do you do communication so that people, carry out the behaviors you want them to carry out, how do you manage, what treatments work? We have very few options, but what do we know that works? Collating information across the globe on what works and what doesn't. So in summary, I don't know about a scorecard, for the whole globe, but I will say that I think that all in all, having been caught unawares, right, we've learned a lot through this process of what it would take to respond to a pandemic. I think moving forward, one of the things that it would be great to see is an integration of the discussion on universal health coverage. What do we do at baseline with the discussion on, how do we respond to pandemics? Because there's a lot of overlap, right? For both, we need to have discussions about information systems. How do you track what is happening in the community? Whether it is NCD or the spread of surveillance for an infectious disease, it's still a conversation about collecting data, analyzing data, and understanding the needs. When we're having conversations about human resource, yes, we should be having conversations about primary healthcare and strengthening for NCDs. But we also need to be having conversations about who goes around and does contact tracing, about who cares for different conditions. So the human resource conversation, the information technology conversation, the financing conversation. We can have a conversation about financing, purchasing primary health care, and for NCDs, but we just described how purchasing supported the COVID-19 response. So in my mind, what would it look like for countries to have a plan, strategies for addressing not just the baseline needs, but a surge, both in terms of information, in terms of human resource, in terms of financing, in terms of service delivery, think along the building blocks. But we've also learned in this pandemic the need for collective action. That this is, the movement addressing a pandemic is not something you can do alone. We're having that conversation now with vaccines. That you have one country vaccinated, and fully vaccinated, and the neighbor is not, then it's just a matter of time. The spread of the virus, new strains, it will spill over. And so I think we also need to have a conversation. WHO has done a great job, but what does it look like to have a mechanism for coordinating on things like lockdowns, on things like distributing vaccines, right? On things like, coordinating supply chains. So one country doesn't have an excess of ventilation and another does not have. Because when one country suffers from an infectious disease outbreak, the whole world is at risk, right? So that those would be the lessons, both at the national level and I think at the global level that we need to take moving forward. A lot of homework for all of us when we get past this pandemic, hopefully very soon.
Wow, your energy and your passion is definitely, it shines through and it's contagious. Before we go to the next question, I just wanted to throw in this plug about the scorecard you mentioned. There is this informal scorecard that people put on social media about countries that did better during the pandemic. And I dare say there were countries that were led by females. Over to you, Dr. Abdul.
Yes, great response on the COVID and everything. So Intala, you made a comment about contracting when we discussed about how you select providers, and there's an audience question on that, and Muiwa at Tegbe would like to know going forward, what do you think, your thought on crowding in private sector into service delivery as a means to improve the quality of care we sought for? So what would be your response on that? And we can't avoid the question of privatization in UHC, because UHC is a trending topic, and mostly the private sector is a bit curious as to how they can lend in their support. Over to you.
Thanks. That's a really good question. It's interesting that in many of the healthcare systems that I have worked in and lived in, the private sector already has a significant role in healthcare delivery. Right? So we have all these really nice papers that were written by Jishnu Das, for example, on India, looking at the distribution, and Karen Greppin, looking at private sector involvement in healthcare delivery. And we see, for some kinds of care, 50%, 60% of the healthcare utilization is provided by the private sector. Unfortunately, the public sector has sort of lagged in our ability to think through, how do we engage the private sector? How do we partner with them in ensuring healthcare provision? And to this end, I think purchasing has a very important role to play, right? So we have two sort of broad tools, I think. We have regulation and we have incentives. So on the incentive piece, that is where purchasing comes in, right? The contract is a very useful tool. Even in Armenia and in Romania, significant private sector involvement, private sector providers are contracted. And what you do with the contract is that you specify the obligations of the provider, right? You specify these are the standards of delivery. You specify what services they can or cannot provide, right? So there you can decide, these are the services we pay for in the public sector. These are the services we pay for in the private sector. We specify the ways in which we pay the provider, different mechanisms of pay, and where the purchaser has significant purchasing power, right? So where the purchaser has a lot of buying power, then that is a tool that can change and nudge the behavior of private providers in direction that is useful to us. Why is this important? Because the variation in quality, the overwhelming evidence we have is that there's significant variation in quality in the private sector, right? So on the far end, I've done some work on traditional birth attendants, and you have some who are handling complicated conditions, of delivery that they should not go near at all, and neonatal. And you have some traditional birth attendants that are more experienced, that are providing, services that are of comparable quality to a well-trained patient. So, what a contract does and what formalizing the obligations of the private sector provider does is that you can have more sort of control over, so signaling to the public what private provider should you visit versus not. Just by having a contract with the purchaser, you're already sending a message. This is the private provider that you should go to. This is the one that you shouldn't, right? But there's also a piece, that for regulation, like I had mentioned a bit when I was talking. So there's a contract and there's payment mechanisms and there's incentives, but there's also regulation, and I'm sure Muyiwa knows this well. He works on this every day. But where you sort of define, these are the standards, right? So having clinical guidelines, otherwise we can't hold them to obligations. What are the guidelines for different services that will be provided? How do we define the mapping of health facilities in a country and where a private provider can go to and where they cannot? So that if you're thinking holistically about our objectives for the system, the combination of the right regulations for citing providers for what they can provide, and incentives that fix the relationship between the purchaser and the provider and the population, then the private sector can become our partner in universal coverage. And that is definitely a preferred alternative to what is happening now, which is a free-for-all in many countries of whatever the private sector wants to do, whatever care, whoever goes, right? And where, there's no conversations happening about harnessing that, but channeling it in the right direction and regulating so we can assure a specific level of quality and access for our populations. So, it was very general, but I hope that it at least begins to hint at the ways in which we can be a bit more structured, I think, in terms of, interacting with the private sector as regulators, right? The Ministry of Health and purchasers.
Wow, Adanna, we're at the 1 hour 24-minute mark, and there's still a lot of questions that unfortunately we cannot get to today. I know we've mentioned this before. We can have a whole conference on purchasing just in of itself outside of healthcare financing. So for anyone who is just joining us, who joined us in the last 10 minutes, we've had the delightful Adanna speaking to us about, paying for universal health coverage, the what, who, why, and whom. Whilst we focused on strategic purchasing, we've really touched on several aspects of healthcare financing as well. And we've heard very valuable recommendations and models from different countries that have implemented different initiatives in that aim and goal to reach universal healthcare coverage. So, lastly, Adanna, for any policymaker or researcher or student or any global health enthusiast who is listening to us and is interested in exploring this subject in depth, are there any helpful resources that you can point the audience to?
Yes, I think my favorite repository for information on purchasing is called Spark Africa, the Strategic Purchasing Africa Resource Center, that has this repository of information on country cases, country experiences, and has a coaching resource so that policymakers, researchers can actually be coached when they're undertaking actual purchasing reform. So I highly recommend that. I also highly recommend the work coming out of the World Health Organization Financing Hub in Europe. Lots of policy briefs I've read recently on benefit package design, very short, easily digestible on strategic purchasing and universal health coverage. And then there is the group in Results for Development led by Cheryl Cashin that have done work for decades on purchasing and some of the work there. And then finally, another shameless plug to the World Bank team and the work that my team has done, on purchasing. You can find it on the Open Knowledge repository. There's a report we wrote on strategic purchasing for better health in Armenia. I think the chapter 4 that looks at the global experiences of handling some of the sticky issues in purchasing is a very nice and short read as well. So these are the things that I would recommend.
That's really helpful, Adanna. And lastly, on public health in real life, one of our main goals is to inspire the next generation of leaders. So I know you've had an interesting journey, having practiced as a physician in Nigeria. I listened to you many years ago talk about being during your national youth service, being at a clinic where you had to attend to maybe it's about 600 patients a day or something. So what has been your journey so far into where you are now in purchasing, and what has motivated you along the line?
Thanks for the question. I think there are a couple of big bullets. I decided really early in my career, I think, what kind of public health practitioner I wanted to be. I think there are different roles, right, that people can have. You can be a researcher, you can be an advocate, you can be a technical expert, like a consultant type person, you can be a policymaker. I decided really early, having experienced personally financial protection being an issue. Receiving care in a hospital, not having insurance, being detained in a hospital myself, practicing as a physician and seeing the difficulty people experience in terms of accessing care, then the huge needs in terms of human resource. I decided really early, I want to be someone who understood the problem really well and helped partner to think through the solution, right? And I think that sort of deciding really early what I wanted to be shaped choices that I made. I put a lot of emphasis on training. My master's in Oxford was an outflow of that. My PhD at Harvard was an outflow of that. A choice of the World Bank, an institution that provides technical advice as well as financing instruments to implement that technical advice, was also an outflow of that decision to become a technical expert. And it's a journey that is ongoing, right? I've had the privilege through the bank to work with countries on designing reforms, on implementing purchasing reforms, on forming twinning partnerships with countries that are further ahead, in these reforms, in rethinking the benefit package, in costing benefit packages, and I keep learning every day about what works, what doesn't work, where and why, to get better. And working with people who are playing other roles, advocacy, policymakers, researchers, to do the work that we do. And along the way, I've had lots of very helpful mentors, right? I've had mentors who are professors in universities that helped me think about what training I needed, mentors in the workspace that helped me think about how to be a leader in teams, especially as a younger person, as a woman of color, who is working in high-income countries. Mentors who help me think about what the career trajectory looks like. What does the next step look like if you're developing your expertise in purchasing? I've also had sponsors, right? People who opened doors for me, who helped, me step into roles that, the next role that I needed. I found that was really important as well. And what motivates me, it goes back to my personal story. It's still fresh in my mind. It's still fresh in my mind as a medical student, lying on that bed, I'd had an accident, I had almost like I'd had a spinal injury and could have gotten paralyzed. And you finish getting cared for, you're learning how to walk again. And your main concern is, how do I pay for my bill? My mother selling off our possessions, her car. It is still fresh in my mind. The reality of living with financial risk when you're seeking healthcare. And so that is my primary motivation. It's me and all the people who have experienced this, and it doesn't feel right. I think for other goods, it might be a bit different, right? I don't have money for a Lexus. Maybe I shouldn't have a Lexus. But I don't think for healthcare it should be like that. I think everyone deserves health. Everyone deserves healthcare because healthcare is important for health, right? And whatever it takes for us to design systems where the reason why you get healthcare is not that you have the ability to pay, is that you need healthcare, I think is the right thing to do. And it's also the smart thing to do because healthier populations are more productive, populations. And so, yes, I hope that answers your questions. I sped through that, but that's my story.
Thank you for sharing your story. That's definitely very, very inspiring. Like I said earlier, we couldn't get to all the audience questions. Thank you for sharing the resources. So if there is anyone who wants to reach out to you with any follow-up questions, what are your social media handles and how can they connect with you?
Good last question. So LinkedIn, you can find me Adanna Chukwuma. On Twitter, I am Adanna DR, Adanna_DR. And I think those two, I'm very responsive because I always, like to reach out and learn from other people so I can get better at doing what I'm doing. So please reach out, send an email. I will respond. If I delay, it will be because I'm busy, not because I don't want to reply. Thank you so much. Maimuna, thank you very, very much, Abdul.
To our audience, somebody just put a comment here. Yes, we all love Dr. Adanna. To our audience, thank you for taking the time to stay with us, to be engaged with us. We know we spent 90 minutes, but I'm sure we will definitely bring you back sometime again, Adanna, to continue this conversation, and hopefully we would schedule more time for this. Thank you to our audience for staying on for this conversation. Thank you to my co-moderator, Abdul. It was a pleasure just working with you. And thank you once again, Adanna. I think, yes, the audience feedback has just been overwhelmingly positive, and it speaks for itself. And to my crew behind the scenes, Kelvin and Ashwin, thank you for just making sure that we've stayed on top of things. And to everyone out there, please stay safe, be well. To our colleagues, our friends, our partners in India, our hearts are with you. For anyone watching, there are several organizations that are supporting work in India. So please go on, donate. Unfortunately, the pandemic is even spreading to parts of Nepal and surrounding countries as well. So please try to work to support all of that work. And to all of our global health enthusiasts, please keep working for health. Keep working to make the world a better place. If you've liked today's interview, like and subscribe to our channel. Please provide feedback on, experts you would like us to bring to this platform to share. And if you're an expert in your field, please reach out to us. We'll be happy to showcase and highlight your work as well. Thank you all once again. You all be well and stay safe. Bye.
Thank you. Bye.